Hi, everyone. Thanks for joining us. We're going to get started. My name is JJ Knight. I am the MMS Outreach Lead for the Measures Management System project. We're excited to present to you the Artificial Intelligence in Quality Measurement presentation. Today, we are supported by Dr. Brian Anderson and Jeff Gephardt will be our presenters this afternoon, and we're so happy to have them to dig into this presentation today. If you would like to download today's slides, they are available on the CMS MMS Hub, which we will share a link to in the chat. We will also post a recording of today's session on the MMS Hub in a few weeks. Next slide, please. Today's topic, we will cover the overview of the Coalition of Health AI, a nationwide network of health AI assurance laboratories, AI assurance and development of and evaluation of clinical quality measures. And my associate Haley, if you're back with us, I'm going to turn it actually over to Haley Von Holst to take you all the rest of the way. Thank you so much.
Hello, hi, sorry about that, technical difficulties, but back up and running. All right, thank you, JJ. So I'm not sure everything you all covered, but my name is Haley Von Holst, and I'm the information session lead for the CMS Measures Management System contract, which is supported by Battelle. So we're very excited today to have Dr. Brian Anderson and Jeff Gephardt presenting this afternoon. So again, we're just really happy for them to be here. I think this is going to be a really interesting session. If you'd like to download today's slides, they are available on the CMS MMS Hub, and we'll share the link to that in the chat. We'll also be recording today's session, and we'll post that on the MMS Hub here in a few weeks. So as part of the Measures Management Systems outreach task, CMS produces these information sessions throughout the year to educate about quality measurement topics and just really engage those who are interested in measure development and maintenance. So in short, we host these sessions for you. So please, as you're listening throughout the presentation today, drop any questions in the Q&A feature near the bottom of your screen, and then we'll have time at the end of the meeting to dive into a few of those. Today, we're honored to have Dr. Brian Anderson discussing a few topics today. Dr. Anderson is the co-founder of the Coalition for Health AI and a chief digital health position at MITRE. And then we're also going to have Jeff Gephardt, which we'll turn it over to at the end of our presentation. And he's the senior research leader in Battelle's health business unit and a CQM subject matter expert on the CMS Measures Management System. All right, and then again, we'll conclude with that Q&A segment. So with that, I'm going to turn it over to Dr. Anderson to jump in.
All right, well, thank you so much, Haley. I'm really excited to be here and have the chance to speak with so many of you about AI and its applications in quality measurement development. So you can go ahead and advance the slide. So just briefly, one of the things I wanted to start off sharing with you about was the Coalition for Health AI. So I'm an internal medicine doc by training, and I've been practicing clinically for roughly 8 or so years before I got into digital medicine, digital health. And it was in digital health that I really started appreciating some of the applications, particularly in predictive AI, in helping to support a lot of the clinical decision-making that providers have. Now, fast forward from those days, 15 or so years ago, to coming out of the pandemic, a group of us, a number of academics from some large health systems and a number of large technology companies, got together 3 years ago asking a very basic question. Is there a consensus technical perspective on what responsible, trustworthy AI looks like in health? The answer that we quickly got to was no. There are a number of health systems, a number of organizations, payers that are out there doing good work in the AI space, but doing it in silos, not coming to consensus in terms of what a definition for responsible or trustworthy health AI looks like. And so we believe that in a consequential space such as health, that it's really important when we build these tools, and that's all AI is. These are tools that physicians, that clinicians, that patients, that developers use in the furtherance of improvement of clinical outcomes in health. And so that was the journey that we started 3 years ago, is developing that definition. If you go to the Coalition for Health AI website, you'll see that there's a blueprint that we published there that describes that. We also published a few other, or excuse me, we plan on publishing a few other assurance guides and checklists there within the next month or so. The organization has grown to now be over 1,300, and I think actually the exact number is 1,387 organizations. And it spans both the private sector and the public sector. It spans academic institutions, health systems, large and small, as well as government organizations. Importantly, CMS is a very active participant in the US government effort around ensuring that we have responsible use of AI. You can see the list of the other agencies there, including the White House, NIST, CDC, AHRQ, ONC, FDA, and many others. CHI in January of this year actually became a formal 501c6 with the real intention of how do we engage this many members with a variety of different use cases to ensure that we have an adequate understanding of how to develop AI, how to deploy AI, and how to maintain AI. And so I'm excited now to dive into some of those, specifics as it relates to payers and quality measurement development. So you can go ahead and advance to the next slide. So there's some really core high-level principles for responsible health AI that I want to make sure I can ground everyone on. And you can see it here on the screen. Around a wheel, there are core values like privacy, security, and resiliency, fairness and equity, usefulness, safety, accountability, and transparency, explainability, and interpretability. Let me dive into a few of these. And a lot of these, I think you're going to see similarities to the strategic approach that many of you take to quality measurement development. So let's look at fairness and equity as an example. When we think about developing AI, there's a concept of unjustified bias. So first off, it's important to call it that all models are biased. Models are biased in particular ways based on the indications and the limitations that are intended to be transparently shared with the end user so they understand how those models are developed, what they're trained on, so that they can use them appropriately, taking into consideration what the bias is. As an example, if I were to build a model that was specifically trained to identify breast cancer or screen for breast cancer and the quality measurements around screening for cancer, that model is very biased and very trained on and should hopefully perform well within that patient population. That's a justifiable bias. An unjustifiable bias is when you train a model to do a specific task, but it's trained inappropriately. It's trained in an unjustified way. As an example, let's use that breast cancer screening diagnosis. If I were to train a model to screen or identify individuals at high risk for breast cancer, but I were to only train it on highly educated, urban, Caucasian individuals, and then to deploy that model and use it in a different set of patient characteristics, African American, Hispanic, less urban, perhaps more rural, or less educated, that would lead to unjustified bias in how the model is performing, its accuracy, and its validity. And so it's really important when we think about evaluating using AI that we understand another key component, which is what was it trained on? What were the input features? So one of the core things that you'll probably hear about as you learn more about AI, if you haven't already heard this concept about model cards, many of the things that are instantiated here in the principles of responsible AI should be identifiable in model cards. This is part of ONC's HT1 rule. If you're familiar with that, it calls out the need for a level of transparency for the end users of AI. In ONC's case, it's clinicians using AI in certified EHRs. But the same application, the same principle of needing to understand where models are trained and what their indications and what their limitations are is really important, particularly when it comes to how we think about driving quality improvement how we think about capturing and measuring quality. You want to be able to understand that models are fully trained on diverse sets of data, diverse sets of patients, so that they have performance characteristics that can be applicable, an AUC or an ROC score, that is indicative of the patients that you're actually using the model. Another one here, let's look at usefulness. So usefulness is a complex one. And so I call it out because oftentimes when we think about AI, we think about, we're very model centric and looking at how models perform, their accuracy, the math behind measuring, the AUC score or the ROC. And yet, you all are probably very aware of this. Healthcare delivery is a very complex milieu, and how we use these tools like AI is really most applicable where the rubber hits the road, at the intersection of how that model is deployed and used in context. In many contexts, it's a clinical workflow, but the clinician and a patient, and then a provider maybe having a pop-up or a button that they press, and a recommendation to drive improvement in quality might come from that. And so understanding concepts like usability or human cognitive bias, and whether or not an individual provider may or may not even listen to that recommendation, is really going to be important. And so how we think about not just the performance scores, but the usability and concepts like human cognitive bias, and if individuals are going to listen to, if they're going to trust the alerts that they're seeing, the pixels that they're seeing on their screens, is a really important concept. Reliability and robustness is another key component. Let me pause here on reliability for a moment. Many of you probably are familiar with ChatGPT. LLMs in general could be classified as generative AI, which is a different category than predictive AI. Predictive AI are closed systems, expert classifiers that are trained on specific things, trained to help screen for breast cancer, trained to identify people at risk for cardiovascular disease. LLMs, as if you've ever gone online and experimented or used ChatGPT or any of the other models that are out there that are LLMs, if you put the same prompt in, it doesn't necessarily give the same response. The output can vary from prompt to prompt. And so how we think about using these kinds of models that don't necessarily have the same kind of reliability as a predictive AI output, it's an important question. And this is a space where we don't have any clear answers yet. And so it's really a space where it takes a level of training and expertise and critical thinking that looks at the risk stratification, meaning, is the model output going to significantly put an individual's health at risk, or is it a low risk environment? And using that as a rubric with which we think about concepts like reliability. Doesn't matter if the output is exactly the same or not. How do we think about that? That concept in responsible AI when a patient, is potentially going to have their life on the line. Testability or validity. These are obviously our concepts. How do we test the performance? How do we measure the performance of these models? Predictive AI, very straightforward. We have mature concepts, testing scripts, and abilities to how do we measure performance, how we measure bias, F1 scores, and things like that. In generative AI, we don't have an agreed upon set. And so one of the messages I want everyone on this webinar to appreciate is that in the generative AI space, this is a science that is just developing. It is immature. The expert community has not come to a consensus on how we think about the measurement or the alignment, how we measure alignment to many of these principles for generative AI. And so that should give a lot of people, all of us, a degree of humility and caution when we think about how we apply AI, particularly generative AI, in a space that's consequential, like an individual's health. I don't want to bother going through all the rest of these, but I definitely encourage folks to learn wherever you can about these concepts, because these are going to be the foundation upon which how you think about and apply AI tools in the development and measurement of quality in clinical care. So let's go ahead and dive into that. Go ahead, next slide, please. All right, so I said at the beginning of that earlier slide that a lot of the principles in responsible AI are very similar to the principles and the strategy that go into developing quality metrics, how we think about driving quality improvement from CMS's perspective. I started off on the responsible AI slide talking about equity. You can see it's front and center here. It's really important that when we think about development of AI and development of quality measures and how we think about driving improvement, that we apply it to the diverse set of population of people that are in our society, and that we look to use these tools in equitable ways across those people. Other concepts like safety, ensuring, and I'll go back to the reliability one as an example, ensuring that we're doing no harm in the reliability or lack of reliability of these models. Or put another way, are these models scores safe and effective? Is the score of 0.9, if you were to measure a model's performance, good enough? How do we think about driving quality strategically using AI tools within CMS? These are questions, again, that we don't all have a consensus perspective on how exactly to do that. And so again, one of the messages that I want you all to hear today is this is going to take all of us leaning in to the space to help define what that consensus is. What does safe and effective mean in the use of AI tools to drive quality improvement? Or how we think about measuring reliably and capturing quality as a metric. Again, there's no clear answer to this. That may not be a satisfying thing for folks to hear, but just being honest with you, this is really a science in a space that is in a shared discovery moment, and it will take the expertise of you all to help contribute to what these shared, agreed upon perspectives are going to be. How we think about alignment, another core strategy goal for quality. How we think about coordinating across the various programs, both within CMS and the clinical care delivery system, is critically important. Of course, interoperability and scientific advancement. Next slide. So let me just spend a minute here on foundational models. So when ChatGPT rolled out, and many of the other large language models, Bard, others, they've been trained on large sets of data and large sets of multimodal data. So this is not just text, as you've seen if you've seen DALL-E or some of the other computer vision algorithms, images, waveform analyses, multi-omic data, so genomic data, proteomic data, as well as graph data, and of course, audio data. The ability for generative AI, for large language models with massive transformers, to take in these kinds of data and to be able to draw the kinds of connections between the different kinds of data is a really critical component to the emergence of capabilities that many of us don't necessarily can't predict. This concept of emergent capabilities draws from an ability in how these transformers, which I won't bother getting into the details here, but how these transformers are built. They're able to draw inferences or connections between, potential cause and effect of different kinds of data or different sets of data within the same category. That's a very powerful capability. It's how human intelligence is sort of based, how we kind of infer cause and effect based on things that we observe, things that we read, and things that we see, and how we're taught. Similarly, in the AI space, these large language models, these foundational models, which just as definition, these are large transformers, billion of parameter size, trillion of parameter size, that take a significant amount of investment to make. GPT-4 is an example of one. The ability for them to be trained on all these kinds of data is very powerful. Now, one thing that's important to note is many of the commercially available applications, or I should say, the commercially available uses or interfaces for these models, those models aren't trained necessarily on the kinds of clinical data at a health system. So it's important to note that these models aren't trained on the data within a health system. And so that again is an important thing to consider when you're thinking about using these models, because one of the important, things that I'll come back to, when I said at the beginning, is how we think about bias and performance. If you're having a model that's not trained on the data that the model is going to be applied to, that's something you probably don't want to do. And so when we think about how we measure quality, how we drive quality, we want to ensure that the models are trained on kinds of data, if not the data from the health system in which it's deployed. And so you can see kind of, again, the list of the categories of the data. And the really, valuable thing here is the ability for these models to draw inferences between cause and effect, and then be able to identify potential risk. And then you get into this concept of being able to stratify risk. So risk stratification, risk prediction, is a core value in many of the clinical decision support models that providers use. If you're able to build a powerful tool, an LLM, that can look across all the different parts of the patient's record and with a certain degree of accuracy, be able to stratify that patient's risk for breast cancer, for hypertension, for cardiovascular disease, and notify providers of whatever that risk score is, and whatever the appropriate intervention might be. That is a very, very powerful tool. Now, the problem, I'm going to come back to one of the principles that I didn't discuss, but which is important to think about here, particularly for CMS. We talk about explainability and interpretability. It's really important as stewards in our society that represent the government, that work for the government, to have an ability to explain and understand how a tool got to the recommendation that it did. That's really hard when you have a foundational model that has these trillions of parameters. Some would argue it's pointless. Explainability is really not possible, so why do we even waste our time on it? It's an important question, though. I don't have the answer in terms of how CMS should think about that. If we have a responsibility to partner with the patients that we cover in our society, to be able to help them understand how these models came to the recommendation that they do, it warrants further investigation and thoughtful engagement with patients about what exactly explainability means, interpretability means, in terms of the output. And equipping our providers with that kind of understanding is going to be really important, because that's how you get to trustworthy AI. Trustworthy AI is critical, because if you don't trust it, I talked about that human cognitive bias earlier, you're not going to use it. So what's the point? Next slide. So I've been talking about some of these concepts within responsible AI in various use cases. I wanted to highlight just a few of them. The first one is model development for outcome risk prediction. I had mentioned, a number of these examples: cardiovascular risk, hypertension, any of the major disease drivers of death. There are clinical decision support tools in the predictive space that have been developed, and in the non-AI space, simple logic rule if-then statements. The CHA2DS2 risk score is an example. That's not AI. It's just odds ratios being applied to a risk score. But with the advent of these foundational models, there's real opportunity to think about, feature sets that are, look at like CHA2DS2. There's like maybe 14 or 15 different features that kind of feed into the odds ratio calculator. These LLMs have the ability to take in, billions of different kinds of data points. Not that you would need that many for something as simple as cardiovascular risk scoring, but the potential is there to rethink how we go about risk prediction. And it's a really important point to call out, because the ability to go from a feature set of 10 to billion is logarithmic, right? It's exponential. And the ability to potentially identify individuals that are at risk in more nuanced ways really becomes possible in a more precise way, in a more personalized way. And I think that's where there's a lot of excitement with these LLMs and generative AI and other kinds of more mature predictive models, is a more personalized way of thinking about risk prediction that is very specific to the individual's journey through health. This is something that CMS identified a number of years ago. You had the AI Outcome Challenge, where you looked at, looked at things like bias mitigation, transparency, and explainability and interpretability. And so I don't want to bother revisiting that, other than to call out that, I think there's important concepts that were tested out and challenged with the participants and the performers, and that encourage people to go back and take a look at that if they haven't. One of the potential areas to look at, right, if we're able to tease out cause and effect and look at that in a more nuanced way, you can get to the kinds of quality metrics that are more focused on actual outcomes than in the process space. So as a clinician, as a primary care doc, I can't tell you how many times I looked at my HbA1c and did I check it every 3 months for my diabetic? Did I measure my blood pressure? These are important, obviously, process metrics that lead to hopefully improvement in clinical outcomes, right? Well-controlled diabetes management, well-controlled hypertension within specific ranges. But the ability to think about other kinds of metrics, again, tied to that outcome, that are more nuanced, that may be lost in all of the analysis and research that we've done to date, because we've never had access to these kinds of models, is there. And so this is a area for research when we think about what are the quality metrics that we could potentially begin looking at if we take these large foundational models and begin training them on longitudinal historical patient data, and then looking for specific clinical outcomes that we want to drive patients towards. So what are the potential interventions that we want to drive, that we haven't identified yet? One of the things that's exciting, I'll share as an example. So causal machine learning is a very hot topic in this space. So models that are tuned specifically on causality or cause and effect is an area of exploration. There are some EHR vendors and academic researchers that are looking at this concept of, if you have a patient, so imagine a physician has a patient in front of them, and they are there, and they have a number of comorbid conditions: diabetes, hypertension, COPD. And they're at advanced stage, so they might be at risk for any number of cancers. Instead of having kind of the what I'll call the protocol driven number of approaches that a provider has go before them for screening, blood pressure management, hypertension, diabetes management, et cetera. Some researchers are looking at, well, taking the corpus of the patient's record, running it through a tuned LLM, tuned in causality, that then has the ability to reference millions of patients, some subset of which are like that person in front of you, and then able to generate essentially a card that says, patients like the one in front of you, Dr. Anderson, have benefited from, X, Y, and Z, and, 1, 2, and 3. And that ability to identify very precise, very personalized potential interventions, and driving providers to potentially make those interventions, is showing some promise that, one, it's driving personalized medicine, it's helping providers drive quality improvement, and it's helping to identify what some of those potential quality metrics could and should be. Again, very immature space. It warrants a lot more research. It warrants a lot of humility. And when we think about this, because health, again, incredibly consequential space. And so we need to be very careful and slow in how we think about foundational models. Next slide, please. So I know I'm going over time. I want to just really briefly. So when we think about measuring quality, right? And so again, as a provider, I've been trained in my revenue cycle management system to capture quality, at all the right times, make sure I do the right thing, capture the blood pressure, capture the A1C score, order the lab tests, et cetera. That process and the extraction of the data and the measurement of it by CMS, captured in this slide here. One of the things that I would encourage everyone to think about, and I challenge you, this slide may be already obsolete within a year. I say that a little bit provocatively, but the point I'm trying to make is these LLMs, right? The substrate, the thing that they use, is not individual. Did you capture his blood pressure? Did you order the test for A1C? Did you do the cancer screening for cervical cancer? It captured those, but it also uses the entirety of the longitudinal record, all of those different kinds of data sets that I showed you earlier. So the question that I would posit is, does that warrant us thinking about how we measure quality? Should CMS, should quality metric measurement services think about leveraging more of that longitudinal record, training it on, using it to train LLMs that are tuned specifically in causality and driving quality improvement and identifying what those quality metrics are? So that's my question. That's my provocative question. I won't give you an answer to it, what my thoughts are, but it's really just a question that I'd urge you guys to consider. Next slide, please. So I'll wrap with an example here. So this is a screenshot of one of the more powerful speech to text models that's out there. I think it's a company called Abridge. Individuals and their providers speak together conversantly. It captures it natively in the EHR as a clinical note with an assessment and plan that's recommended. And it's a really powerful tool. The speech to text ones, another great one is Nuance. There are quite a few out there. The ability for these tools to capture that whole conversation and then also leverage the whole record and then display right on the screen for the provider, what the recommendations are, summarize the note, summarize what the potential quality improvements are, and then having that all be powered by generative AI and the ability to summarize clinical notes is happening right now. Within the past year or two, just really transformational things have begun to happen. As one of the co-founders of Chai, I have the privilege of working and seeing a lot of this right in front of me. It's truly a transformational moment. It's almost breathtaking when you think about what it's going to be like within 2 years. And so that's why I really encourage everyone to think about how we reimagine capturing quality. These tools are transforming providers and patients' lives right now. And it's going to happen, next, I think, in the quality metric, quality improvement space. So with that, I will pass it off to Jeff. But before I do, just one last thing. The Coalition for Health AI is having a webinar. We're going to be discussing a lot of these things. It's a big webinar. The commissioner of the FDA is going to be keynoting it. It's going to be really exciting. It's on Tuesday, March 5th at 11:30. I think there's a link in the chat window if you'd like to register and tune in for that. It should be a lot of fun. We're looking forward to having some important things to share. So with that, I'll end my presentation, pass it over to Jeff. Sorry I went over time, Jeff. Over to you.
Yeah, no worries, Brian. Thank you so much. Hi, everyone. Brian has just sort of described this new and emerging future where these AI tools are really likely to be transformative in the development and evaluation and use of clinical quality measures in the near future, maybe sooner than we had anticipated. So Brian has demonstrated these tools may be used to extract more meaningful clinical data. They might define emerging new ways to improve outcomes and establish new means of implementing those ways. So our consideration here is, what is that potential impact on the way we think about developing and evaluating clinical quality measures? Next slide. So the place to start is where we've already been. So what lessons might we draw from recent innovations, such as patient-reported outcome measures and electronic clinical quality measures, and consider in what ways is AI similar to these innovations, and in what ways is AI different? And so with respect to patient-reported outcome measures, so these are instruments that are developed by instrument developers using sort of rigorous processes and evaluation criteria. And then these instruments collect data that are then used and implemented in a clinical quality measure. We call those pro-preems. And I think there's an analogy here where we have these AI tools that are developed by AI developers. They'll be evaluated using rigorous processes and evaluation criteria. They'll generate data that, again, will be used in a clinical quality measure. So just in the same way that when we evaluate the clinical quality measure, we don't necessarily evaluate the instrument upon which it's based, that evaluation is kind of done as part of a separate process. There's probably an analogy here where there's going to be AI tools that are developed in a somewhat separate process. We will use the data that are generated by those tools in our clinical quality measures. We'll want to know their properties, and we'll want to know their sort of pluses and minuses, but at the end of the day, it's somewhat of a separate process. Similarly, with electronic clinical quality measures, as these have evolved, they're heavily reliant upon standards. So everything is done consistently in the same way. Everyone kind of does it the same way. And in this case, as Brian kind of mentioned, some of the activities of the coalition is developing some of these standards. So just like we have things like the quality data model, clinical quality language, US core, all of these standards that have emerged, we're going to be developing sort of a similar set of standards for clinical quality measures that incorporate artificial intelligence in some respect. Next slide. So an important kind of first step in this, as Brian mentioned, is this idea of the model cards. And so this is a draft model card that has been under development in the natural language processing community of practice. And I just wanted to give you a sense of what these model cards look like and the kinds of information they include. So for NLP, we might have different sets of information requirements for an NLP model that is based on more machine learning methods, and then a separate set of information requirements that are based on rule-based methods. And they go through, how they were trained, how the details, how the rules are developed, how they're maintained. Next slide. And I think the important thing about these model cards, and I would very much encourage you, if you're interested, to reach out to us. We would love to get your input on this emerging model card, because I think it's very important that the clinical quality measure community has input into the way that these model cards get developed. Are they capturing the kind of information that we need in order to evaluate whether these AI models should be incorporated into our clinical quality measure specification and implementation? So with respect to measure development, there's really sort of three key things that these model cards provide. One is the consistency. Every potential AI model that could be incorporated in a measure is evaluated in a very explicit, consistent way. The second is transparency. Next slide. How the thing was developed, who developed it, what sort of processes were involved in the development, what do the testing results look like? So model cards serve that goal of transparency. And the third goal that model cards really support is the idea of stewardship. And this is very important in clinical quality measures. If we're going to incorporate an AI model into a clinical quality measure, that model needs to be supported and maintained over time. And so the stewardship of these AI models is going to be sort of a critical feature of what is of interest in a clinical quality measure application. So model cards serve all of these principles. The other thing that model cards do is they help AI developers consider issues they might not have otherwise considered that are particularly important to quality measurement. And so that's why the clinical quality measure community really needs to be involved in the development of these model cards. And again, I would encourage you, if you're interested, to reach out to us. We'll share the model card that we've been sort of developing in the consideration of natural language processing. We would love your input. Next slide. So as been some of the questions that have been coming forth are really about how do we think about these AI tools and incorporating these AI tools in the context of clinical quality measure evaluation. So with respect to measure evaluation, the key concept is net benefit. So every clinical quality measure and every medical intervention, for that matter, involves both benefits and harms to both persons and entities. And when we talk about the benefits and harms and the net benefit of a clinical quality measure, we're not just talking about the AI tool itself. We're talking about the AI tool as it is incorporated into a quality metric and a quality program. So Brian was discussing how context is important, implementation is important to really understanding what the impact of these AI tools is. And this is a critical consideration when we think about what the potential effect might be of incorporating an AI tool in a clinical quality measure. In that context, the way that persons respond to the measure, the way that clinicians respond to the measure, what are the benefits that are produced by that? What are the potential harms that are produced by that? We need to be very explicit about what those are, and so we can evaluate sort of net benefit. The other thing that is of critical importance is feasibility. Are these tools, do we know what are the people, the processes, the technologies that are required for implementing these tools? How widely available are these people, processes, and technologies? Are there any sort of particular persons or entities that might not have access to these people's processes and technologies? We need all that to be very clearly spelled out. Not only are we sort of interested in the net benefit for kind of a representative person or entity, what we're really critically interested in is how that net benefit might be distributed across the population, both of persons and entities. So there might be overall a net benefit, but not everyone might share equally in that net benefit. And we're critically interested in, from perspective of evaluating a quality measure that incorporates an AI tool, about how that net benefit is distributed across the population. And then finally, as Brian has described, this is a rapidly evolving field. The things that are true today might not be true tomorrow. And as we mentioned, the model cards really support this concept of stewardship and sort of maintaining these things over time. And so these are not sort of static concepts. They will evolve. The models themselves will improve and evolve. And so we need to be able to take into consideration how that net benefit might evolve over time, and what we can do to sort of intentionally sort of move it in one direction or another. Next slide. So we don't really have, sort of, if we're thinking about sort of net benefit, we don't really have sort of well-articulated frameworks for understanding sort of the different aspects of net benefit. But there are some lessons from some other disciplines that have similar concerns about the net benefit of technology and interventions that are helpful and informative to us. So environmental justice has very similar concepts and considerations that I think would be helpful to us when we think about applying an AI tool in a clinical quality measure. So one is the concept of inequality. So that's the circumstance where the AI tool just works better for some person or entity than it does for another person or entity. And if the reason that it works better for a person or entity is some kind of structural characteristic of that person or entity, that might not be something that we make a policy decision about, but it's certainly something to be aware of, that the net benefit might not be the same for everybody. And so that sort of generates an inequality through the use of an AI tool. Inequity is what we typically think of, where the AI tool might have been trained on a population that wasn't representative, or simply that access to the AI tool might not be equally shared. And there might be certain disadvantaged populations of entities or persons that don't have access to the tool or have a significant burden in terms of implementing that tool. And so we're concerned in quality programs about any potential inequities that might be generated. And then finally, an injustice is where there's a specific policy about either encouraging or promoting the availability of a technology that doesn't apply widely and actually makes some of these inequities potentially worse. So we want to be concerned about all three of these aspects and be explicit about them as we evaluate the potential impact of these AI tools. Next slide. So in summary, so the impact of AI on clinical quality measure development and evaluation use is probably likely to be pretty profound. So first, there's this whole new set of AI assurance activities that are likely to be the responsibility of the AI tool developer based on industry standards. And then the CQM development will need to incorporate new processes to be able to evaluate and incorporate these tools into our clinical quality measure development activities. Second, tools like AI model cards will support consistency and transparency in stewardship and ensure that the AI tools underlying clinical quality measures are supported over time, which is, to my mind, a critical consideration. Third, CQM developers who want to propose the use of clinical quality measures in programs will need to demonstrate that the impact of these AI tools have on the net benefit to persons and entities in the study population that they use for their measure development. And then fourth, there's probably going to be a greater role, my anticipation would be, for CQM implementers that will need to take an active role in establishing that kind of external validity. Okay, we know the properties of the measure and the tool on a study population, but how is it going to apply to a population that's involved in a particular program? And implementers may have to take a more active role in establishing that external validity for that intended use, including the distribution of net benefit across persons and entities, and the identification of any issues of inequity, inequality, inequity, and injustice. That might be just there's going to be need to be a sort of this national infrastructure, these insurance labs to help us inform those concepts that might be sort of beyond what a typical clinical quality measure developer would have access to sort of individually. So I'll stop there and turn it over to JJ.
Thanks, Jeff. I appreciate it. While our presenters review your questions, I'll make a few brief announcements before we jump into Q&A. Next slide. First, I would like to invite you all to an upcoming public webinar on patient safety. Quality counts, safety matters, prioritizing patient safety through quality measurement. You'll hear from representatives from CMS, CDC, ARC, and the VHA. There are 2 opportunities to attend, so just select the one that's best for your schedule. Next slide. And second, the 2024 pre-rulemaking process is underway. We are hosting the 2024 pre-rulemaking public webinar on March 28th to learn about this year's pre-rulemaking process and measure selection considerations. We'll also have a session on the ins and outs of how to submit a measure through CMS Merit during the CMS Merit Tips and Tricks webinar on April 16th. To learn more about pre-rulemaking, I encourage you to visit the pre-rulemaking webpage on the CMS MMS Hub. All right, I'm going to turn it over to Haley for our Q&A. Thanks so much.
Great. All right. Thank you so much. I see a flurry of questions, so thank you. These are wonderful questions. Thank you so much to our presenters. So we will, let's just jump right in. So our first question goes to Dr. Anderson. So what about the studies that show AI is giving false results, and what has been done to review biased algorithms?
Great question. I was hoping you'd call on that one first. So I didn't get to talk about a concept that Jeff was referring to, which is this idea of assurance labs. So one of the concepts that's, I think, core to development and use of any tool in a consequential space is assuring that it's safe and effective. Is it going to break on you? Is it going to do something bad? And in this case, James, the person who posed the question, is giving the great point that some of these AI models are giving the wrong answer. And it can either be patently false, a hallucination, or a confabulation, or it can be, just inaccurate, not the right response or not the best response. These assurance labs are a critical part of the testing of models and sharing transparently in those model cards that Jeff was referring to. There's a part of it that is, what is the performance score? What are the indications and limitations for that model? These assurance labs, in a transparent way, are meant to test these models for, James, for the things that you're calling out, for false inaccuracies, for, not the best answer, other kinds of biases, meant to be able to essentially offer an independent validation of how these models are performing. So that's one kind of way that we're addressing the biases or reviewing the inaccuracies of the model, is this independent evaluation. The other core part of it is local validation. So the ability to test and monitor performance of a model locally where it's deployed. That's the other core thing that health systems need to develop when they're deploying these kinds of models locally to drive quality improvement, is how is it actually working on the patients in front of me? And there are dashboards and companies out there that are delivering in the space. Really, I think part of the challenge, though, the unanswered question is that just means health systems have to stand up additional resources to monitor these things. There's a lot of questions in that space that we haven't answered yet, particularly with under-resourced groups. I know, Jeff, if you had additional thoughts on that.
Oh, I think that sounds great.
Great. All right. And we do have a lot of questions coming in, so we're going to do our best to get to as many as we can, but we might follow up with the group after if we don't. So here's a question for Jeff. We have, where does DMS see generative AI helping with quality measurement in the future?
Yeah, I think it's interesting because, as Brian was describing, it's emerging area. There's a lot that's unknown. There's a lot of research on sort of the psychology of large language models and things of that nature. But I think in some ways, clinical quality measurement is kind of a good use case for these large language models, because we already have existing processes and infrastructures for a lot of human review, right? So that's sort of the key, right? You use the large language models to generate some input, and they're great sort of contextual engines, right? They just can generate all sorts of interesting linkages that might not otherwise be immediately apparent. But we have existing processes through technical expert panels or review panels to sort of make sure that any kind of claims that are generated from that content, undergo human review. And so I think there's a lot of potential in sort of three areas in clinical quality measurement. One is that we often don't know a lot about the potential harms of a quality measure. We know a lot about the benefits, but in terms of like potential unintended consequences or harms, it's hard to get that out of the literature. And so large language models, I think, could potentially help us identify some of those potential harms. The second thing is we often don't have a clear articulation of what the mechanisms are that are responsible for improved performance. It's hard to articulate what those mechanisms are, and large language models can help us sort of be more explicit about how one achieves a certain kind of performance, what the kind of mechanism pathway is. And the third area is around context. All of these mechanisms are performed in a wide variety of contexts, and we need to understand what the impact of that context might be on the ability to perform on a quality measure. And I think in all three of those areas, in the short term, large language models have great promise. In the longer term, I think there are some questions about using large language models to help sort of populate standards. And I think there is this kind of interplay between, sort of unstructured or making connections between disparate data elements and populating standards that I think is going to be sort of interest, going forward, reducing the burden of potentially, using standards for data extraction.
Wonderful. Thank you so much, Jeff. Let's do another question here. So another question for Brian. So could the notion of showing providers a profile for patients like this create a bias against diagnostic procedures or lab work? So for example, if we don't test for an issue and that data isn't part of the patient's record.
Yeah, this is a great question, Lindsay. This is the dark field effect. If you're not testing for it or asking for it to be done, you're going to not have the data to be able to, further refine or tune models that are, constantly learning dynamically. And so the short answer is yes. I mean, this is, I think, one of the challenges that we come into as we move forward in the use of AI. We're essentially going to be creating data sets that reinforce certain pathways. And so this concept of model fit or model overfit, we're going to be training models that are going to be constantly learning and reinforcing, those pathways, because the data that's being generated is taking individuals down certain paths, and not down others. And so, I would say there's no easy answer in how we get out of that, other than we need to be sure that we're, periodically looking at other data sets that haven't necessarily been used to be trained on. So you'd call these new data sets that haven't been exposed to model training, or at least the models that you want to have be trained on them, for the potential, so that you're not going down the model overfit path.
Wonderful. Thank you so much. And I think that is all we have time for today. So I know we only have a minute left, so we'll wrap up pretty quick. Again, there are some fantastic questions we will follow up on after this. And also, if you have any other questions about the material that we shared today, please reach out to that email that we sent into the chat, so the MMS support email, and we can connect you to anything that you need. So thank you so much to our presenters, and hope everyone has a wonderful rest of their day.
Thank you.
Bye-bye now.